APAP, the toxicity. Basically, in this video, we'll be presenting to you information about APAP, or what we all know as paracetamol toxicity. So first, we will be presenting you details on the properties of paracetamol, where you will be able to have the overview of our agent. And this will also include its mechanism of action, its mechanism of toxicity, and its toxic doses. Second, we will be presenting to you the clinical manifestations shown in the 4 phases of intoxication. Third will be its diagnosis. And last is the management. So now, you already have the outline of our presentation. Then, what are we waiting for? Let's get it on! Paracetamol is actually N-acetyl para-aminophenol, which is a widely used over-the-counter and prescription analgesic and antipyretic. It is usually available at the dose of 125 milligrams and an extra strength of 500 milligrams. It is also available in suppositories and available in 120 milligrams, 325 milligrams, and 650 milligrams. Other concentrations are also available, although not that widely used. Paracetamol acts by interfering with prostaglandin synthesis through inhibition of prostaglandin synthetase in the arachidonic acid cascade in the CNS.
Mechanism of toxicity. One of the products of normal metabolism of acetaminophen by the cytochrome P450 mixed oxidase system is hepatotoxic. Normally, this reactive metabolite is rapidly detoxified by glutathione in the liver. However, in overdose, production of the toxic metabolite exceeds glutathione capacity and the metabolite reacts directly with hepatic macromolecules, causing liver injury. Renal damage may occur by the same mechanism owing to renal metabolism. Toxic dose. Acute ingestion of more than 140 mg per kilogram in children or 6 grams in adults is potentially hepatotoxic. Children younger than 10 to 12 years of age appear to be less susceptible to hepatotoxicity because of the smaller contribution of cytochrome P450 to acetaminophen metabolism. On the other hand, the margin of safety is lower in chronic alcoholics and the other patients with induced cytochrome P450 microsomal enzymes because of the more toxic metabolite may be produced in these patients. As mentioned earlier, there are 4 phases of acetaminophen poisoning. The phase 1 occurs at 0.5 to 24 hours after ingestions. Symptoms include anorexia, nausea and vomiting, malaise, diaphoresis. Transaminases may be elevated, however, patients may appear normal. After 24 to 72 hours of ingestion, phase 2 of the poisoning happens. Here, anorexia, nausea, and vomiting become less pronounced. Right upper quadrant pain may be present. The transaminase levels continue to increase. Bilirubin level may be elevated. Prothrombin time may be prolonged, and the renal function starts to deteriorate. Phase 3 of the poisoning commences after 72 to 96 hours of ingestion. This is characterized by the sequelae of hepatic necrosis, which is jaundice, coagulation defects, renal failure, and hepatic encephalopathy. Worse, death due to multi-organ failure may result. If the patient survives phase 3, phase 4 of the toxicity happens. This occurs 4 to 14 days after the ingestion of too much paracetamol. Includes the complete resolution of hepatic dysfunction and the liver heals without evidence of fibrosis. Diagnosis is possible only if the ingestion is suspected early and the serum acetaminophen level is obtained. To obtain a 4-hour post-ingestion acetaminophen level, use the nomogram Rumack-Matthew nomogram to predict the range of severity. Also, the use of laboratory data such as CBC, electrolyte level, glucose, BUN, creatinine, liver and renal function tests, and prothrombin time has been useful. Treatment. Treatment includes emergency and supportive measures. Supportive measures include the treatment of vomiting. as vomiting may delay the administration of antidote and charcoal. Use metoclopramide at 10 to 20 milligrams IV, and for children, use 0.1 milligram per kilogram. Also, provide general supportive care for hepatic or renal failure if it occurs. Liver transplant may be necessary for massive hepatic failure. The use of specific drugs and antidotes take responsibility if the serum level falls above the possible toxicity line on the nomogram or if stat serum levels are not immediately available. Use acetylcysteine or N-acetylcysteine at 140 mg per kilogram administered orally. The effectiveness of this therapy depends on early treatment before the metabolite accumulates. It is of minimal benefit if started after 12 to 16 hours. If vomiting interferes with oral acetylcysteine administration, give it by gastric tube. The contamination of patient may also be helpful. The first decontamination method is by the induction of emesis or performing of gastric lavage. Second is the administration of activated charcoal and a cathartic. However, activated charcoal may interfere with the absorption of the antidote acetylcysteine. To avoid this, charcoal may be removed by lavage before acetylcysteine is given, or the dose of acetylcysteine may be increased. Gut emptying is probably not necessary following small ingestions if activated charcoal is given promptly. Hemoperfusion effectively removes acetaminophen from the blood but is not generally indicated because antidotal therapy is so effective.
So, there you have it. Always remember that taking too much paracetamol is not as safe as what you think. So, be careful in taking paracetamol and other medications. Next time, see ya!